So imagine you are walking into a high-end clinic. You are there for a really cutting-edge regenerative treatment,
Right.
specifically intimate PRP. That stands for platelet-rich plasma therapy. It's a procedure that's increasingly used in sexual medicine to rejuvenate those highly sensitive vascular tissues.
Yeah, it's becoming incredibly popular.
It is. And so you are sitting in that clinic chair looking around the room, and you might naturally assume that the absolute most important factor in whether this treatment actually works is, I don't know, the expensive, futuristic-looking centrifuge spinning in the corner.
Or the doctor's credentials.
Exactly. Maybe you think it comes down entirely to the clinical skill of the doctor holding the syringe.
And, well, it makes complete sense to think that way. I mean, as humans, we are drawn to the things we can actually see and measure.
Right. Yeah.
We look at the shiny technology and we just assume that is the whole story. But in the incredibly precise world of regenerative medicine, the real heavy lifting is actually happening on a microscopic level.
Like long before the injection even takes place.
Exactly. Way before.
Yeah, because I was reading through this stack of sources for our deep dive today. We have some fascinating recent clinical reviews, some biomedical studies from MDPI, and a few incredibly dense hematology research papers.
Very dense.
So dense, but it completely shifted my perspective. Because it turns out the hidden hero of your entire treatment, or potentially the hidden villain if things go wrong,
Right.
is an invisible chemical sitting quietly at the very bottom of the plastic blood collection tube.
It's amazing how much that one detail matters.
It really is. So today, our mission is to unpack the exact science of how the choice of anticoagulant in that tube radically alters your treatment. We are specifically looking at the battle between two chemical solutions, ACD-A and sodium citrate.
The heavyweights.
The heavyweights, yeah. We're going to figure out how they determine the viability of platelets, especially in something as delicate as intimate PRP.
It is a critical battle, honestly, and the stakes are surprisingly high when you zoom in on a cellular level.
So where do we start?
Well, to really grasp this, we need to take a step back and look at what PRP actually is. I mean, it's essentially the process of harnessing the body's own localized healing mechanism.
A natural repair crew.
Exactly. A clinician draws the blood, isolates a plasma, and creates a highly concentrated serum that is, up to 94% platelets.
People often call it liquid gold, right?
Yeah, they do.
Because you are taking your body's own workforce, concentrating them into this massive army, and setting them exactly where you want them to go.
That is the goal. But here is the massive biological hurdle we have to jump over first.
Okay.
The moment blood leaves your vein and hits the plastic of a collection tube, a biological alarm bell rings.
Because it knows it's outside the body.
Exactly. The blood registers that it is outside the body, and its immediate, desperate instinct is to clot.
Right. Which makes sense.
Yeah, that is what it is evolutionarily designed to do, to stop you from bleeding out. But to successfully harness PRP, we have to pause that biological clock.
We have to halt the entire clotting process.
Right, but we have to do it without damaging the incredibly delicate cells we are trying to harvest.
See, that just seems like a massive contradiction to me.
How so?
Well, how do you completely shut down a natural bodily process in a tube, but keep the cells perfectly healthy and alive so they can work later?
It's a delicate chemical dance for sure. To stop the coagulation cascade, these chemicals, the anticoagulants, perform a very specific action called chelation.
Chelation.
Yeah. In chemistry, to chelate essentially means to grab onto or bind to something. These anticoagulant chemicals are designed to seek out and tightly bind to ionized calcium in the blood.
Wait, calcium. Like for strong bones.
Like for bones, yes. But in the blood, calcium is the vital required trigger for the blood clotting process.
Oh, wow. I didn't know that.
Yeah, so if you hide the calcium, the blood literally cannot clot.
Okay, so it's like taking the spark plugs out of an engine.
That's a good way to put it.
Like the car is there, the fuel is there, but without the spark, the calcium, the whole process just cannot physically start.
Precise.
But if the only goal is just to stop the clotting, why is this such a big debate in the clinical world? Couldn't a doctor just use any standard blood thinner?
Like what?
Well, like heparin, for example. I mean, heparin is everywhere in hospitals, right?
It is everywhere, yeah. And heparin is indeed a remarkably potent anticoagulant. It's brilliant at stopping clots in a general medical setting.
Not for PRP.
No. The clinical reviews in our sources are extremely clear on this. It is a terrible choice for PRP.
Why?
The problem with heparin is that it operates differently than just hiding the calcium. It actually causes the platelets to prematurely activate and clump together
Right in the tube.
right there inside the collection tube, what we call aggregation.
Wait, so the platelets are waking up and trying to do their healing job while they are still just sitting on the clinic counter
Precisely. And that is a disaster for tissue regeneration.
because they are wasting their energy.
Exactly. Because of that premature activation, heparin significantly decreases the actual recovery of usable platelets. And more importantly, because they activate in the tube, they dump their crucial growth factors early.
Oh, no.
Yeah, those healing proteins are essentially spilled into the plastic tube, meaning they are completely lost before they ever reach the patient's tissue.
Okay, I love a good visual.
Yeah.
So using heparin for PRP is essentially like hiring a bouncer for a highly exclusive VIP club.
Okay, I'm following.
But the bouncer is so aggressive that he just kicks all the VIP guests out into the alley before the party even starts.
That captures the dynamic perfectly. You just have an empty club by the time you open the doors.
So heparin is out.
Heparin is out.
So if heparin fails because it's way too aggressive and triggers the platelets early, the logical next step for scientists would be to find something that prevents clotting without triggering the platelets, right?
Right.
Which brings us to EDTA.
Ah, yes. EDT.
Because I noticed this came up a lot in the research. I mean, if you go to your doctor and get routine blood work done, it's almost certainly going into a tube with EDTA in it.
Yeah, it's the universal standard.
So why not just use that?
Well, because it is the gold standard for diagnostics, a lot of early regenerative medicine researchers naturally assumed it would be the perfect solution for PRP. I mean, why reinvent the wheel if EDTA already keeps blood from clotting so effectively?
Makes sense. And according to the early data in the sources, they thought they hit the jackpot.
They absolutely thought they did. And this leads us to one of the most fascinating scientific mysteries in the recent history of hematology.
Ooh, a mystery.
Yeah, for years, automated counting machines were being completely fooled by this. There was a very notable early study by a researcher named Aizawa and colleagues.
Right, I read that one.
They looked at the raw data coming out of the hematology analyzers, and the machines were reporting that EDTA yielded the absolute highest raw number of platelets compared to anything else.
Which sounds amazing. I mean, if I'm paying for a regenerative treatment, I want maximum platelets.
Of course you do.
But you said the machines were being fooled. How does a highly calibrated medical device just get it wrong?
It took a very meticulously designed, prospective-paired clinical study to uncover the truth.
What do they do?
Researchers finally decided to take blood from the exact same patients at the exact same time, put it into different tubes, and actually look at what was happening on a cellular level.
Instead of just trusting the raw numbers from the machine.
Exactly. And what they discovered is that EDTA causes what scientists call a calcium chelation-induced artifact.
An artifact.
Yeah.
Like a glitch in the visual data.
Basically, yes.
What was the glitch?
Remember how we established that anticoagulants need to bind to the calcium?
Yeah, the chelation.
Well, EDTA binds to calcium irreversibly and with an incredibly high aggressive affinity.
So it doesn't just hide it.
No, it doesn't just hide the calcium, it violently strips it away from the cellular structure entirely.
Oh, wow.
Yeah, and that action functionally damages the delicate membrane of the platelet itself.
Just from ripping the calcium out.
Exactly. And when that membrane is damaged, it loses its ability to regulate its internal pressure, which causes the platelet to massively swell up.
Ah, I see.
Yeah.
So the automated machine is scanning the sample, it sees these massive bloated shapes, and it just registers them as large, robust, healthy platelets.
That's exactly what happens. But really, it's just looking at damaged, dying cells.
That is wild.
The data shows EDTA systematically overestimates platelet size, what we call the mean platelet volume, by up to 26%.
26%.
Yeah, it is a complete illusion.
It's like taking a water balloon that is designed to hold a very specific amount of liquid and inflating it way past its capacity.
Perfect analogy.
And then the machine scans it and says, look at this huge, impressive balloon. But the walls of that balloon are stretched so dangerously thin, and the structure is so compromised that it can't actually do what it's supposed to do.
That is a much more accurate way to look at it. And the functional consequences of that stretched, damaged membrane are severe.
What happens?
Well, despite those high automated counts, the swelling drastically limits the platelet's physical ability to release its crucial growth factors.
Oh, because it's broken.
Right. And one of the most important growth factors is VEGF. the vascular endothelial growth factor.
Okay, and what does VEGF actually do in the body? Like, why do we care if the swollen platelet can't release it?
VEGF is essentially the master architect for building new blood vessels.
Oh, okay.
Yeah, when you are trying to rejuvenate sensitive, intimate tissue, the primary goal is often restoring robust blood flow.
Right.
VEGF signals the body to literally construct new vascular pathways. If your platelets are swollen and damaged by EDTA, they cannot release the architect.
And no architect, no new blood vessel.
Exactly, no regeneration.
Wow, so EDTA is essentially a morphological mirage.
A mirage, yes.
It looks fantastic on a spreadsheet. The machine gives it a high score, but it leaves the doctor holding a syringe full of broken, bloated cells.
Which is useless for the patient.
Right, which means we need something that stops the clotting, doesn't wake the platelets up like heparin, and doesn't destroy their membranes like EDTA.
And that finally brings us to the two main protagonists of our deep dive, sodium citrate and ACD-A.
Finally.
This is where we transition from just stopping blood clots to actually providing microscopic life support.
Okay, I like the sound of that.
Both sodium citrate and ACD-A rely on citrate to chelate the calcium. But the fundamental difference, the reason they succeed where EDTA fails, is that citrate binds to calcium reversibly.
Reversibly.
Yes.
So going back to the car analogy, it's taking the spark plugs out to stop the engine, but keeping them safely in your pocket so you can put them back in when you actually want to drive.
Precisely. We need the platelets to stay completely asleep and dormant in the collection tube, but we absolutely depend on them waking up and activating the moment they are injected back into the target tissue.
Right, because if they never wake up, they don't heal anything.
Exactly. Reversible chelation makes that synchronized delivery possible. Now, let's look at sodium citrate first.
Okay.
It is widely used and very cost-effective. But more importantly, it provides a very clean, neutral environment for the cells.
Neutral, meaning not harsh.
Right. When a clinic uses basic sodium citrate, it yields what we call high-purity platelet-poor plasma with a very low risk of chemical contamination.
So sodium citrate is like the solid, reliable, clean baseline.
Yes, exactly.
But then the sources introduce ACD-A, and they frame it as this supercharged premium variant.
It is quite different.
Yeah, ACD-A stands for acid citrate dextrose solution A. So it has the base of sodium citrate, but it adds two massive variables, citric acid and dextrose.
Right.
Why would a clinic go through the trouble of adding these extra chemicals if standard sodium citrate already works?
To understand why those additions are so crucial, we have to look at the final destination of the PRP.
Where it's being injected.
Exactly. Where is this injection actually going? In the case of intimate PRP, or sexual medicine in general, we are often injecting into highly sensitive and frequently hypoxic environments.
Hypoxic meaning the tissue is starved of oxygen.
Yes.
Which makes sense, because if you are getting regenerative treatment for intimacy issues, it's very often because the natural blood flow, and therefore the oxygen supply to that specific area, has been compromised over the years.
Exactly. The tissue is literally struggling to breathe, and this is where the dextrose and ACD-A becomes a metabolic lifeline for the platelets.
Because dextrose is a sugar.
It is a simple sugar, yes. You have to remember, once these platelets are drawn out of your arm, they no longer have your body's steady, continuous supply of nutrients.
Oh, true. They are cut off from the supply chain.
Exactly. So when the doctor injects them into a hypoxic tissue, those platelets cannot rely on oxygen to generate the energy they need to work.
So what do?
They have to switch their metabolic engine to glycolysis, which is the process of making energy directly from sugar.
So the dextrose in the tube isn't just a preservative. It's actual fuel.
It is high-octane fuel. The dextrose provides the exact energy substrate they need to survive in that harsh environment.
That's incredible.
It sustains their mitochondrial function, it keeps those delicate cell membranes stable, and most importantly, it gives them the massive amount of energy required to actively synthesize and pump out growth factors once they finally wake up.
So if sodium citrate is just putting the platelets to sleep for the journey, ACD-A is putting them to sleep and packing them a highly nutritious lunch so they have the energy to work a double shift the moment they arrive in this oxygen-starved environment.
A very nutrient-dense lunch, yeah. And the yield data from the clinical studies heavily backs this up.
Does it really make that big of a difference?
It does. Because they are so well nourished, ACD-A increases the overall platelet recovery rate by 10 to 17% more than standard sodium citrate.
Wow, just from the sugar.
But it's not just about the raw number of platelets. It's about what they're armed with. The sources show ACD-A yields significantly higher concentrations of vital healing proteins, specifically TGF-beta1 and PDGF-BB.
Okay, let's break those down.
Yeah.
We talked about VEGF being the architect for blood vessels earlier.
Right.
What do TGF-beta1 and PDGF-BB actually do when they hit the tissue?
They are the heavy machinery of tissue repair. PDGF-BB acts essentially like a chemical flare gun for your body's stem cells.
A flare gun, I like that.
Yeah, it signals to stem cells and fibroblasts in the surrounding area, calling them directly to the site of the injection.
Come over here, we have a problem to fix.
Exactly. Then, once those cells arrive, TGF-beta1 acts as the foreman.
Telling them what to do.
Yes. It instructs those newly arrived cells to start aggressively building new collagen and extracellular matrix. It physically rebuilds the structural integrity of the tissue.
Okay, the dextrose makes total sense, and the growth factors sound incredible.
Ugh.
But I have a major question about the other ingredient in ACD-A, the acid part.
Ah.
Because the sources explicitly note that ACD-A drops the pH of the blood down to about 6.5.
That's correct.
That is notably acidic. If we are talking about intimate PRP, meaning a doctor is taking a syringe and injecting this fluid into some of the most highly sensitive, densely innervated nerve clusters in the entire human body.
Yes.
Wouldn't injecting acidic plasma just burn? Doesn't that risk damaging the very tissue we're actually trying to heal?
That is an incredibly astute observation, and it is a very real clinical concern in sexual medicine.
So I'm right. It would hurt.
You are entirely correct that injecting a fluid with a pH of 6.5 into highly innervated tissue would cause a sharp, stinging sensation. And it isn't ideal for the local tissue environment at all.
Then why do they use it?
Because that acidity serves a vital, non-negotiable purpose during the preparation phase in the laboratory.
What does the acid do in the lab?
That specific pH drop to 6.5 is the exact chemical threshold that keeps the platelets perfectly quiescent.
Quiescent.
It forces them into a deep chemical sleep. Remember how we said the centrifuge was a violent process?
Right, spinning them at crazy speeds.
We are spinning these cells at immense speeds to separate them. The acidity acts as a shield, preventing them from getting stressed and activating prematurely during the trauma of centrifugation.
Oh, I see.
It guarantees that those precious growth factors, the flare guns and the architects, stay locked safely inside the platelet until the very last second.
Okay, I understand the need for the deep sleep chamber during the centrifuge ride. But that doesn't solve the problem of actually injecting acid into a patient.
No, it doesn't.
How do clinics get around that?
This is where clinical skill intersects with chemistry. In premium, highly controlled clinical protocols, a doctor will not just draw the acidic PRP out of the machine and inject it directly.
Oh, they don't.
No. Right before the injection takes place, they will introduce a buffering agent, typically a highly precise amount of calcium chloride.
Hold on, calcium chloride. They're putting the calcium back in.
Exactly.
Wait.
Remember the spark plugs?
Yeah. The citrate in the tube hid the calcium to stop the clotting cascade in the first place.
Right. And by reintroducing calcium chloride just moments before the injection, the clinician triggers two massive chemical shifts simultaneously.
What happened?
First, the calcium chloride acts as a buffer, neutralizing that acidic 6.5 pH back up to a comfortable physiologic level, completely eliminating the burn.
Oh, wow.
Second, introducing the calcium purposefully reactivates those deeply sleeping platelets at the exact synchronized moment they hit the target tissue.
That is just phenomenal.
It's beautiful chemistry.
It's not just drawing blood. It is a fully engineered, synchronized biological delivery system. It's biochemistry in real time.
It really is.
So we've clearly established that ACD-A creates a much more robust, well-fed, and heavily armed platelet, especially for these hypoxic intimate tissues.
Definitely.
But it also sounds incredibly complex. Does sodium citrate still have a place in modern clinics? Why would a doctor ever choose it over ACD-A if ACD-A is so much better?
Well, it comes down to a clinical balancing act. You are weighing maximum biological yield against maximum simplicity and patient comfort. ACD-A is widely considered the absolute gold standard for high-quality clinical-grade PRP, especially by premium brands operating in aesthetics and sexual medicine. But sodium citrate has some very unique practical perks.
Like what?
For example, there was a fascinating retrospective study in our sources conducted by Chen and colleagues. They weren't looking at intimate PRP, though. They were looking at osteoarthritis patients.
Like pain, which is another massive exploding area for regenerative medicine.
Exactly. And the principles of localized tissue reaction are very similar. Chen's team looked at patients receiving PRP injected into their knee joints.
And what did they find?
They found that patients receiving PRP prepared with a very low dose of 4% sodium citrate actually experienced measurably less post-treatment pain.
Really? Less pain.
Yes.
Yeah.
Furthermore, when they analyzed the synovial fluid in the joints, those patients had significantly lower levels of inflammatory markers compared to patients treated with higher dose, more complex anticoagulants.
So even though it doesn't have the packed lunch of dextrose, sodium citrate might actually be gentler on the tissue on the front end.
It can be. The reality is that anticoagulants in general, regardless of how advanced they are still foreign chemicals.
Right. Your body doesn't naturally have citrate just floating around like that.
Exactly. And they have occasionally been linked to localized adverse reactions, things like temporary erythema, which is redness, localized swelling, or even slightly delayed healing in the immediate days following the procedure.
Oh, gotcha.
Sodium citrate offers a highly pure, incredibly simple plasma. The trade-off is clear, though. You might get a marginally lower overall platelet yield, and you definitely get less longevity.
What do you mean by less longevity?
ACD-A is such a good preservative that it keeps platelets stable and viable in a clinical setting for up to 7 days.
7 days. That's a long time outside the body.
It is. Sodium citrate's viability window is much, much shorter. But if a clinic is drawing the blood and injecting it immediately, and their primary goal is a very clean, neutral injection that might result in slightly less immediate post-injection inflammation, well, sodium citrate remains a highly valid clinical choice.
Okay, so if you're listening to this and you are sitting in that clinic chair, getting ready for this procedure, this is the ultimate takeaway.
Let's hear it.
Your regenerative results aren't just relying on your underlying biology. They certainly aren't relying on how sleek and modern the centrifuge looks.
No, they aren't.
The success of something as deeply personal as intimate PRP is intrinsically tied to the invisible chemistry happening right behind the scenes.
Right.
It is about knowing whether your clinic is using ACD-A to provide your platelets with that dextrose energy source and a temporary acidic sleep chamber, guaranteeing they arrive at the tissue perfectly preserved, heavily armed, and ready to rebuild.
It perfectly highlights the reality of cellular medicine. Every single variable matters.
Every single one.
The chemical in the tube isn't just a passive preservative to make the doctor's life easier. It actively dictates the therapeutic potential of your cells.
That is just wild to think about.
But as we look to the absolute latest frontiers mentioned in the source material, this entire debate raises one final highly provocative question.
Oh, I love looking at where the science is headed next. What is on the horizon?
We just spent this entire discussion dissecting how both ACD-A and sodium citrate, despite their benefits, carry slight inherent risks.
Right, the redness, the inflammation.
Exactly. They can cause minor allergic reactions, pH imbalances, or temporary localized inflammation because, at the end of the day, they are foreign chemicals.
Right.
So researchers are asking, what if the ultimate future of intimate PRP isn't about choosing the best chemical anticoagulant?
Wait, then what is it?
What if it's about learning how to eliminate them entirely?
Eliminate them completely.
Yeah.
But you said earlier that the second the blood hits the plastic, the alarm bells ring and it clots immediately. How is that even possible?
Yeah. It does clot, but researchers are now exploring the emerging cutting-edge science of fluid platelet-rich fibrin, often abbreviated as FPRF.
Okay, FPRF.
This is a completely anticoagulant-free preparation.
Really?
Yes. By using highly specific, specialized, low-speed centrifugation and completely chemical-free specialized glass or plastic tubes, they are learning to actually harness the blood's natural clotting matrix.
So they aren't stopping the clot.
No. Instead of fighting the clot, they use the resulting fibrin web as a natural, slow-release scaffolding for the growth factors, totally avoiding the downsides of citrate, acid, or dextrose exposure.
So they are completely bypassing the chemical debate altogether, working with the body's alarm system instead of against it to create a purely natural, slow-release healing matrix.
Exactly.
That is a wild thought to leave on. The next time you find yourself amazed by medical breakthroughs, don't just focus on the flashing lights of the new machines or the sleekness of the clinic. Because sometimes the most profound differences in a healing journey come down to the invisible chemistry sitting quietly at the bottom of a plastic tube.